Well, the other one I wanted to tell you about from this morning had to do with sedation. The AMA has a committee called the RUC, and they were assigned the task of looking at sedation and creating a code for sedation. Right now, when you do an endoscopy, the sedation is assumed to be part of that procedure. And CMS would like to take sedation out of the procedure so that if you don't use sedation, say you use an anesthesiologist, then you'd get a further decrease in your reimbursement. Now, this can be very problematic. In my own practice, I'm frequently using anesthesia for my sickest patients. So I don't think it makes sense to give me a financial disincentive to doing the right thing, which is having my patients, get anesthesia when appropriate. So we're very concerned about this. When the RUC did a survey of various specialties, GI being only one of them, they really ended up with a bimodal distribution where GI said, that's about 5 minutes of work, which is similar to what we've done in 5 prior surveys. It's about an extra 5 minutes of work, where the other societies said it was more like 15 minutes. And so that's a triple. CMS, though, heard us, and they said, yeah, we agree with you. We don't agree with the other evaluation, at least as it goes to endoscopy. So I think it's pretty clear that the effect on endoscopy will probably not be large, that if there's a cut, it'll be a very small one, that CMS did hear us on this. So I think we are making some progress there. Yeah, the ICD-10 codes went into effect this month, and we've heard from members that for certain ICD-10 code diagnoses that those are being rejected by CMS for some reason. And CMS acknowledged, yes, there is a problem. Initially, our members were instructed to delay billing until January, which we think is unacceptable, to wait 3 or 4 months to submit your bill. CMS heard us loud and clear on that. They are working on solutions. It may be a software issue, and we hope that will be solved relatively soon. Yeah, I think that, we've always been concerned about what CMS is doing. The federal government funds about half of all medical care in the United States, so it has a big effect on our members when they make changes. And so the current changes that don't just include reimbursement, but regulatory changes, changes related to electronic health records and meaningful use, these are significant burdens. And I think that we're probably at the tipping point where smaller groups, solo practitioners, are probably not going to be able to continue business as usual with Medicare patients. And I think you're going to start seeing groups not seeing Medicare, opting out of Medicare, solo groups also opting out, because it's just too complicated and too expensive to try to continue to do this. We did a survey of members, and we found that probably 40 to 50% are going to make some change regarding Medicare in order to deal with all these problems, either limiting the number of Medicare patients, opting out altogether, moving patients from the low-cost ASC to the higher cost but higher reimbursed hospital. We're seeing that being discussed. And in fact, 20% of the members said that they would consider early retirement because it's just too much regulatory burden and work for them. It takes them away from doing what they want to do, which is taking care of patients. Well, if you opt out, you're out for 3 years and you can't take any Medicare patients at all. Patients can still see you, but they're paying out of pocket. So we certainly don't advocate that at all. We want to take care of all of our patients, but CMS may be starting to put us in a bit of a bind. At least some of our members, where having the kind of resources that a large institution would have to deal with all of this, they just don't have in a single group or group up to say 4 or 5. So you're going to see more groups consolidating, more hospital-based and employed physicians, and it's really going to do damage to the private practitioner. You get out of the big cities, and it's all small groups and solo practitioners, and so anybody who's not living very close to a large city is going to be affected by this. And this can affect everybody, because if people start refusing to take insurance, or they move into the cities to join hospitals, or they're not seeing Medicare patients, or they take early retirement, this is going to affect everybody's care, not just people with Medicare insurance. Yeah, well, I think first of all, staying involved is really important. So maintaining your membership in the professional society, the ASGE, which is the one that I I represent, I think is really important. I think also when we have these conversations, we have to make sure that we're really clear on our professionalism. This is really an attack on our professionalism. When our professionalism comes into contact with declining reimbursement or unfair policies, this really makes it very difficult for us. So we need to really double down on our professionalism, always putting the needs of the patient first. And when we're talking about reimbursement, what it really is, it's really about patient access to care, because at the bottom line, the end of the day, that's what it's about. It's making sure that patients can get the care that they need. And if it's not going to be paid for, it's just not going to happen. People just won't be able to take care of those patients.